Hello everyone. This is the third and last part of this video on how to appraise a clinical trial. In the previous part, I reviewed the easy questions to ask while appraising a trial, and in this part I'll review the challenging questions. As with part 2, I've grouped the questions by sections of the paper. First, regarding the title, there's nothing more to say than I did in part 2, but now I want to talk a little about the authors. And in some ways, this is one of the most challenging of all the questions because the answer may not be in the paper itself. What are the author's potential conflicts of interest? All investigators start off their studies with some form of internal bias. In the best case scenario, that internal bias is the result of them wanting to prove right a hypothesis that they really believe in just for the benefit of our greater scientific knowledge. In the worst case scenario, investigators are designing studies specifically to maximize the chance of a particular result because they're receiving research funding or other perks from the pharmaceutical and medical device industries. Such blatant conflicts of interest are required to be disclosed in peer-reviewed journals, but these disclosures are so common that clinicians don't really think about it when reading papers. But we should. We should be more skeptical of a paper written by doctors who are supported by the manufacturer of the drug that is tested in the trial. That does not mean that industry-supported docs are probably lying or that the paper is invalid. But even the most honest investigators can be unconsciously swayed in how they design a trial or analyze the results. Other conflicts can exist besides industry influence, and often they are less overt. For example, when a researcher who is well known in a specific field for a specific hypothesis would suffer some degree of professional embarrassment if their latest study contradicted the idea for which they are known. That kind of conflict of interest is not going to be disclosed in the paper. The only way that you as the reader will think about it is if you independently research the background of the investigators themselves, and that takes a lot of time and is very rarely done or discussed. There are no additional questions about the introduction, so I'll move to the methods. The biggest question here that we haven't addressed in part 2 has to do with endpoints. In part 2, I discussed the difference between primary versus secondary endpoints, but now let's talk about a different way to classify them: subjective versus hard versus surrogate. Subjective endpoints are just that, subjective. The most common subjective endpoints are based on patient self-reporting of symptoms. For example, in an RCT of a new inhaled bronchodilator for asthma, an endpoint could be patient reporting how short of breath they felt. Or in RCTs of antidepressants, the presence and severity of depressive symptoms are obviously a very common endpoint. Subjective endpoints are very susceptible to the placebo effect, which is why blinding is particularly critical in such studies. An unblinded trial using a subjective primary endpoint is useless and should not influence patient care. In contrast, so-called hard outcomes are objectively measured endpoints which are of direct interest to the patient. This is primarily mortality, but could also be hospitalizations or objectively measured functional disability using a standardized assessment tool. So then, what's a surrogate endpoint? Surrogate endpoints are objective and are thought to be related to a patient-centered endpoint like mortality, but which they themselves are not directly visible to the patient. An example is tumor size in cancer patients. Does a patient with lung cancer feel physically different if their tumor shrinks from 4 centimeters to 3 centimeters? Probably not, but they care about it because they believe that the smaller the tumor is, the better their treatment is working, which translates to a higher chance of cure or longer life expectancy. Tumor size is a surrogate endpoint. The problem is that surrogate endpoints don't always show good correlation with endpoints of actual primary interest to the patient. For example, just because a particular chemotherapy drug decreases tumor size, it doesn't necessarily mean that those patients will live any longer or have a higher quality of life if the drug has no impact on the probability of metastasis, or if the drug is so toxic as to lead to kidney failure and increased mortality from that mechanism. Other examples of surrogate endpoints include blood pressure and hypertension, serum LDL and hyperlipidemia, and hemoglobin A1C and diabetes. Doctors and patients alike focus on these numbers and try to make them better with medications and lifestyle modifications, but we don't always know if an improvement in some lab test that's the result of a specific treatment actually translates to a lower mortality or a higher quality of life. If hard outcomes are the patient-centered ones, why do investigators ever choose surrogate primary endpoints? They're used because they require a much smaller sample size and a shorter trial to show an improvement that is statistically significant. But the problem is that not all surrogate endpoints prove to be valid. So, as a general rule, researchers should try to avoid surrogate endpoints, but if that's not possible, which is frequently the case, they must ensure that their choice of surrogate is appropriate. Another related question about endpoints. Does the study use a composite endpoint? Composite endpoints combine multiple different endpoints into one metric. For example, a study of early stenting in non-ST elevation MIs could use an endpoint that combined all-cause mortality, recurrent MI, or need for an urgent trip to the cath lab in the 2 weeks following the MI. I personally hate composite endpoints. They are always misleading, and by mixing clinically important hard outcomes like death with events of a much lower concern to patients, like urgent cath, they usually make interventions look more beneficial than they actually are. But composite endpoints are commonly used for the same reason that surrogate endpoints are. They allow sample sizes to be smaller, which makes the study cheaper. This is because the most dangerous and adverse of endpoints, such as death, occur with the least frequency. Now, just as you should not disregard studies using surrogate endpoints, I'm also not saying that you should disregard those using composite endpoints either, because if that was the case, you'll end up ignoring the majority of cardiology literature from the last 20 years. But if a trial with a composite endpoint is being portrayed as a positive one, you need to make sure that the benefit seen was not solely due to something of relatively small importance to the patient, which happened to have been bundled into that composite. Another question to ask in the methods is whether the trial is a superiority trial or a non-inferiority trial. So what's the difference between those? In a superiority trial, researchers are trying to demonstrate that the intervention works better than the control. And in a non-inferiority trial, researchers are trying to demonstrate that the intervention works either as good or better than the control. In my opinion, the most important reason to make note of this distinction is because some types of study design flaws, including underpowering, will increase the chance of concluding non-inferiority, even if the new intervention is indeed inferior. This is because underpowering obscures differences between groups when a true difference exists. This is the opposite problem that's seen in superiority trials, in which underpowering leads to the rejection of beneficial therapies. In other words, if you are a drug company trying to demonstrate that your new and expensive medication is superior to an established treatment, you're going to work really hard to make sure your trial is not underpowered. You'll recruit plenty of patients and account for plenty of potential dropouts. Even if the magnitude of benefit is tiny, if there is a huge number of patients in the trial, that benefit still might reach statistical significance. But on the other hand, if your goal is to demonstrate that your new and expensive medication is non-inferior to an established treatment, your incentives are totally different. Underpowering will actually benefit you in the sense that it will increase the chance your new drug looks just as effective as what's already in use. The next question under methods is whether the methods used were representative of common practice. As one example, consider the very well publicized SPRINT trial published in 2015. SPRINT was an RCT of patients with hypertension and increased cardiovascular risk, but without diabetes. The intervention arm was intensive antihypertensive treatment with a blood pressure target of systolic under 120. The control arm was standard treatment in which the systolic target was under 140. The primary outcome was a composite one that combined acute coronary syndrome, stroke, heart failure, or cardiovascular death. Much to many people's surprise, investigators found there to be such a statistically significant benefit to the intensive treatment that the trial was stopped early. There are several huge problems with the SPRINT trial, but one of them had to do with how the blood pressure of patients in the trial was measured. Ask yourself, in conventional medical practice, Outside of clinical trials, how do medical professionals measure patients' blood pressures in the outpatient setting? Typically, patients come into the clinic, sit in the waiting room for a period of time, are brought back to some private or semi-private area by a nurse or nursing assistant who then immediately measures the blood pressure using an automated cuff. That pressure is then recorded for the doctor. If the pressure is normal, or at least not surprising, the doctor does not usually recheck it. But if it does seem particularly unusual, the doc might recheck with a manual cuff. Now, one would think that in a trial comparing two different blood pressure targets, that the method of measuring blood pressure would be similar to what's done in practice. However, in SPRINT, patients were roomed by a healthcare provider attached to an automated cuff, and then the provider left the room. The automated cuff then measured 3 blood pressure recordings over the next 5 minutes with the patient alone. Have you ever had your blood pressure measured in that way? Unless you are a participant in SPRINT, probably not. And there is a strong consensus that so-called attended blood pressure readings, in which the medical professional is right there next to the patient during the measurements, are higher on average as compared to methods in which the patient is alone. That's the phenomenon known as white coat hypertension. So when doctors were treating SPRINT patients in the intervention arm to a systolic pressure of 120, that may translate to a real-world target of 125, 130, 135, who knows exactly? Because investigators used a strategy for measuring observations which was unconventional and not reflective of real-world practice, the validity of the trial falls into doubt. Let's move into the results. In addition to what has already been discussed in Part 2, there's 3 more questions. First, are the results clinically significant? Clinical significance and statistical significance are not the same thing. For example, one could create an RCT of a new antihypertensive medication, recruit 50,000 patients, and end up measuring an average reduction of systolic blood pressure by 0.5 millimeters of mercury. Due to the huge sample size, this might meet statistical significance, but such a small difference will have a negligible impact on an individual patient's cardiovascular risk. Likewise, imagine a new chemotherapy drug that increased life expectancy in advanced cancer by 5 days. Assuming the drug has side effects, and all drugs do, most patients would not find that to be a sufficient benefit, which of course suggests that when we think about clinically significant benefit, we need to start considering our patients' goals and values. What if the chemotherapy drug lengthens survival by 5 weeks? Is that clinically significant? It might be, depending upon the side effect profile and how the patient weighs quantity versus quality of life. And this will lead us to the final step of practicing EBM, how to apply the evidence to your specific patient, which is covered in the next video in this series. The second question in the results: does the trial emphasize absolute risk reduction or relative risk reduction? Absolute risk reduction is the difference in the probability of an adverse outcome between the control and the intervention arms. Relative risk reduction is the difference in the probability of outcomes in proportion to the original probability. For example, suppose we are comparing a new medication to prevent kidney damage in diabetics using a placebo as the control, with the primary outcome of hemodialysis dependence at 5 years. And suppose the prevalence of hemodialysis dependence at 5 years in the intervention arm was 3%, and in the control arm it was 4%. In this case, the absolute risk reduction would be 4 minus 3, or 1%. If patients were told that they needed to take an expensive medication every day in order to lower the probability they would need hemodialysis in 5 years by 1%, many would probably decline. However, consider if the benefit is described in terms of relative risk reduction. This is calculated by taking the absolute risk reduction and dividing it by the risk of the adverse outcome in the control group. So 0.04 minus 0.03 divided by 0.04, which of course is 0.25. This gives us a relative risk reduction of 25%. So instead of telling patients that the risk of requiring hemodialysis is reduced by 1% from the drug, One could instead say that the drug leads to a 25% reduction in risk of hemodialysis dependence relative to their baseline risk. A 25% reduction sounds way more impressive than 1%, but it's very misleading. It's the 1% that actually matters. So if a trial's authors are emphasizing a large relative risk reduction instead of a small absolute risk reduction, to me it suggests that the authors are trying to spin a statistically significant but clinically meaningless result as a clinically significant one. The relative risk reduction is just a fancy way of lying. And if the authors are needing to resort to such measures to make the trial look more positive than it really is, I would worry about what other less apparent steps they have been taken to achieve the same end. The last question in the results. Was the trial stopped early? Why would a trial be stopped early? When a clinical trial is designed, investigators are required to set specific thresholds of likely benefit or likely harm, which if the incoming results cross during the course of the study must be stopped at that point. This is felt to be necessary on ethical grounds. For example, if a 4-year trial of a new medication was being conducted, but just 2 years in, the evidence seemed overwhelmingly strong that there was benefit to the med, it would be seen as unethical to continue having patients randomized to placebo. So instead, the trial ends early, and all patients in both arms are given open-label access to the medication. Conversely, if partway through the trial there is overwhelming evidence that the medication is causing harm, it gets stopped early too because randomizing people to a dangerous intervention is also seen as unethical. So, as far as appraising a trial that was stopped early, what's the problem? Well, using statistics, it can be shown that trials that are stopped early due to crossing a pre-specified threshold for either benefit or harm have a tendency to overestimate that effect. In other words, a trial of medication X, which was stopped early due to perceived clear evidence of benefit, will more likely than not measure a beneficial effect of that medication which exceeds its true benefit. Likewise, a trial of medication Y, which was stopped early due to perceived clear evidence of harm, will more likely than not measure a degree of harm that exceeds its true harm. And not only is this a theoretical effect, it's been empirically shown to be true as well. Trials that are stopped early have a tendency to show a greater degree of benefit or harm than those which run their entire pre-specified duration. When we get to the discussion section, there's probably not more questions to ask regarding what's been explicitly written by the authors, but this is a good place to mention a few summative questions about the paper overall. First, is there evidence of systematic bias? I've mentioned bias plenty of times already, but to remind you, systematic bias is anything that erroneously influences the outcome of a trial beyond chance alone. Bias can either sway a result towards or away from the null hypothesis. That is, it can either sway a trial towards a negative result or towards a positive one. Let me run through a few types of systematic bias, most of which we've already touched upon, but under different names. There is selection bias, which occurs when there is inherent differences in the types of patients who undergo intervention versus control, or an inherent difference in the types of patients who participate in the study at all and those who decline. The former is prevented by adequate randomization, while there may be no way to address or even uncover the latter. Next is something called performance bias. This occurs when there are systematic differences in the care provided to subjects aside from the intervention. For example, if one arm of the trial received closer follow-up due to the nature of either the intervention or the control. This might be seen in an RCT of warfarin versus placebo for patients with low-risk AFib, in which one could have easily imagined that the anticoagulation arm would get closer medical follow-up on account of the necessary frequent INR checks and complications resulting from the anticoagulation. Closer follow-up means the potential to have minor problems uncovered, which may either have never been picked up in the patients on placebo or may have progressed to something far worse. Performance bias is prevented by double blinding. Detection bias, occasionally referred to as measurement bias, is due to a difference in outcome assessment between the intervention and control arms. It is prevented by standardized definitions of outcomes and by double blinding. Exclusion and attrition biases are very similar, and sometimes these terms are used interchangeably. Most formally, exclusion bias exists when some study subjects are excluded from analysis despite their outcome data being available to the authors. This is prevented by intention to treat analysis. Attrition bias exists when outcome data is not available because patients completely dropped out of the study. Attrition bias is particularly problematic when dropout rates are high or unequal between the intervention and control arms. And the only way to be sure that attrition bias is not present is to have equally high follow-up in both arms. Another way to frame the presence of bias is to ask, is the study valid? Validity in a clinical trial simply means an absence of bias. There are two kinds of validity. First is internal validity, which is present when the study results represent truth about the sampled population. Internal validity requires most of the key features of a well-designed clinical trial that we've already discussed: randomization, allocation concealment, double blinding, appropriate control, low dropout rate, and use of intention to treat analysis. Second is external validity, which is present when the study results can be generalized beyond the sample population. In other words, the sampled population is representative of the general population. One of the most important determinants of external validity in a clinical trial is the number of exclusion criteria. A trial is unlikely to be externally valid if it only included patients within a specific age range, had disproportionate representation of one gender or one ethnicity, only included patients with a specific subtype of the disease in question, or excluded all patients with any significant comorbid medical conditions. A well-written paper about a clinical trial will specifically discuss how many patients were initially screened for the trial but were not enrolled, and the reason for this, which gives the reader some insight into its external validity. Another summative question is one that will require additional investigation on your part. How does the trial fit into the greater body of knowledge related to the clinical question? More specifically, does the trial reaffirm or contradict research or conventional wisdom on similar questions? And have the results been duplicated by other trials? Any trial whose results suggest a major paradigm shift should be viewed more skeptically. Just as a patient's pretest probability of disease depends not just on the result of a diagnostic test, but also on the pretest probability of the disease, the probability that a clinical trial's result represents truth depends upon both the statistical strength of the trial as well as the pre-trial probability that the proposed hypothesis is true. A lot of people forget this point. I've seen doctors not infrequently treat a so-called positive study of a bizarre, unheard of treatment to be just as true as an equally sized and powered positive study of a common and conventional treatment in which the results were entirely predictable. This was also highlighted by the SPRINT trial that I talked about a few minutes ago. Finding that such a low blood pressure target was beneficial was very surprising to primary care doctors, to cardiologists, and to hypertension experts. It contradicted prior research and decades of expert opinion. While expert opinion absolutely can and should be critically re-examined when high-quality evidence contradicts it, evidence that contradicts expert opinion also needs to be examined that much more critically as well. Finally, and this one will also require a little bit of additional research on your part, has any information come to light about the trial after the original paper was published? For example, consider the ROCKET-AF trial. ROCKET-AF was a non-inferiority trial of the new anticoagulant rivaroxaban compared to the well-established anticoagulant warfarin for the prevention of strokes and systemic embolism in patients with non-valvular atrial fibrillation. 3 years after the trial was published, the specific device used to measure the INR of the patients in the warfarin arm was recalled because they systematically provided falsely low readings. This would, of course, result in warfarin doses being increased to inappropriately high values, which could have explained one of the most notable findings of ROCKET-AF, that patients on warfarin had higher rates of intracranial and fatal bleeding compared to rivaroxaban. Despite the fact that ROCKET-AF was the primary piece of evidence used by the FDA in granting approval for rivaroxaban, the systematic bias introduced by the faulty INR meters is such a problem that I personally consider the trial to be uninterpretable, with its major value being its role as an example of why one needs to search for subsequently published commentary on a trial before concluding your appraisal process. That's the end of this three-part series on appraising clinical trials. But before the cut to black, I want to come back to something I mentioned at the beginning of part 1. Appraising clinical trials, particularly some of the more challenging questions, is not an easy skill. It takes time and deliberate practice. Before everything that you just watched fades away from your memory, I strongly encourage you to look up some trials relevant to a recent or current patient of yours and to go through the appraisal process. This skill cannot be mastered without practice. There will be a link in the video description to a document listing all of the questions and significant terms that I've mentioned in this series. And with that, please remember to like or share the videos if you found them helpful. And of course, thanks for watching.